Good afternoon. I'd like to thank the association for inviting me to speak today and compliment all of you for resisting the temptations of the golf courses, tennis courts, and shopping to be present here today. And finally, I'd like to welcome you to Indian Wells, California. I've had the good fortune to call this home for the last 30 years. I have no conflicts concerning this presentation. There are many ways hospitals have tried to incentivize and align physician behavior. Early efforts at providing incentives to physicians through gain sharing met with some limited success. However, value-based healthcare delivery models do confirm that close coordination with stakeholders can result in sustainable improvements in quality and the reductions in the cost of healthcare. More recent gain sharing programs by the CMS have taken these concepts to the next level. Hospitals are basically concerned with quality patient outcomes while generating the highest revenue with the least cost. Surgeons, on the other hand, are typically concerned with quality patient care and best outcome without really consideration of cost. And I think it's because of the lack of prior business education. I mean, it's hard to become a doctor. You don't have a lot of time to do business studies as well. But the lack of the prior education, familiarity with cost analytics, logistics, result in the physician's limited understanding of the institutionalized cost of delivering healthcare. Hospitals have to avoid the cheapest is best philosophy where cost is king. However, on the other hand, the surgeons must have to understand cost analytics and agree to collaboration. So with open dialogue and cost transparency, the stakeholders can better understand each other's perspective. The physician can come to understand the institutionalized cost of delivering healthcare, while the healthcare representatives can understand what it's like to be a physician requiring appropriate equipment, assistance, and supplies that enable them to deliver the best medical outcome. However, as we all know, the bottom line is, in the end, it's the physician that's ultimately responsible for the quality outcome, regardless of what the cost is. Apologize. Educating the physician on the cost of healthcare delivery, incentivizing adopting change, and peer pressure often result in positive behavior modification of the surgeons. Limiting variation during procedures frequently improves the quality, and we found that the goal through this whole process is compromise and collaboration. Today we're going to take a look at the co-management model. Our goal will be to define the co-management agreement, explain the benefits for both the physicians and the hospitals, and define how to successfully execute an agreement and identify challenges and risks. A co-management agreement creates a shared responsibility between the hospital and the physician leadership to improve the quality and efficiency of patient care. The arrangement is typically between one of the following three ways. It's between a hospital and a single physician, a hospital and a joint venture created and organized by physicians of a single group practice, or it can be between the hospital and a JV that's created and operated by physicians of multiple group practices within the same specialty. The CMA ensures that the orthopedic physicians assume minimal financial risk by requiring dedicated hospital infrastructure, such as management of facilities, clinical data, financial data, and outcomes gathering. The CMA assumes the orthopedic physicians retain control and autonomy of their practice. The CMA may include the entire service line, including inpatient and outpatient surgery, ancillary services in some or all of the hospital locations. The CMA basically will include a base management fee, and that is for administrative services, day-to-day operations guidance, medical director agreements, and basically pay the doctor or the physician group a fee for that basic management skill set. Next is quality performance improvement metrics can then be added, for which a bonus fee can be paid based on achievement. When creating the CMA, the basic management and administrative jobs already done by a service line administrator employed by the hospital cannot be included. Services should be reviewed periodically to ensure they are relevant and appropriate. The CMA must include a methodology to track and document the performance of these services by the orthopedic physicians. We would suggest that the hospital and surgeons always engage a qualified valuation consultant to determine what the fair market value compensation is for the co-management agreement. The service line net revenue is a key element in determining the overall compensation, and the service line net revenue must be clearly defined and can be adjusted occasionally for patient or payer mix. The hospital and physician should obtain a fair market value updated at least biannually. Execution of the CMA requires assembling a team of the stakeholders: surgeons, service line coordinator, operating room director, materials and management, as well as nursing. The surgeons are in an advisory role and will need the hospital administrative support of any changes that are suggested. But we have to establish the common goals of quality patient care, quality outcomes, and cost effectiveness. The CMA's goal is to achieve quality patient care and outcomes at the least cost with the highest profit, resulting in value to the organization. The CMA includes a list of incentive fee performance metrics as well. Let's talk about the selection process for metrics. Metric selection should take into consideration the practicality of tracking the actual performance of the co-management incentives. They should be challenging but achievable. It is important to secure physician buy-in in an effort to incentivize their behavior. And that's where peer pressure comes in. When you run a metric meeting, nobody wants to be the person in red up there that is not performing the metric when everybody looks over and says, hey, you're costing me money. Peer pressure really aligns behavior. The number of metrics that are required is based on the valuation, but I'd suggest you take the least amount necessary so that you can keep good physician focus and not dilute the incentive fee. When new processes are created, I'd also recommend that you use the first 6 months in development and implementation, and then measure the second 6 months. The CMA will assign a weight to each performance metric for the purposes of computing the incentive fee that includes targets for each performance. And you can use national benchmarking, AAOS or ACS, national surgical benchmarks, to help create these performance metrics. The metrics have to be objective, they have to be measurable, and they have to be based on service line development, quality improvement, and efficiency. The patient population and the analytics must be clearly defined. As with all agreements between hospitals and physicians, assuring appropriate legal compliance is mandatory. All valuations and compensation must be at fair market value. Transparency and reliable processes must be created to assess the performance metrics. Thorough documentation, including physician time logs, is essential to ensure compliance. I'll tell you a story about cement, because I think this is one of our metrics that incorporated all the aspects of creating and executing a successful metric. This is one of our initial metrics, actually, and I wanted something simple. I wanted something with high utilization, so I picked cement. I mean, who can argue about cement, right? So when we analyzed cement utilization, we found out that there was way overutilization in the operating room, opening too many bags per case. There was overutilization of antibiotic impregnated cement, which is many times more expensive. And we were having multiple cements provided by multiple vendors at a variety of costs. Through the metric process and with the agreement of surgeons to utilize cement in appropriate indications, achieving the physician buy-in, we were able to move to a cost-effective vendor, secure hospital support for enforcement, which resulted in high physician satisfaction, excellent patient outcomes, and more than $500,000 annual savings just going to one cement vendor. There are many challenges, however. The CMA requires active participation and effort by very busy physicians. Documentation requirements are rigid but must be enforced. The documentation requirements are done by the physician, and they're always checked by the hospital and the evaluation outside source. One of the problems is you can grow the service line. The orthopedic surgeons may not be able to share in all the rewards the hospital may reward by building the service line. Resolutions over disputes over the achievement of metrics are not uncommon. And the co-management agreements may have a relatively high regulatory risk, so both the parties must demonstrate fair market value compensation. As with all medical agreements, they come with a variety of legal risks that must be considered. However, co-management agreements can be created and executed successfully by utilization of an independent valuation consultant. All compensation, including the base fee and all the incentive fees, need to be at fair market value. The agreement itself, as well as the execution, must be transparent. All stakeholders must adhere to documentation of their time and efforts creating, executing, and achieving the administrative duties and completion of the metric process. In the end, a co-management agreement creates a shared responsibility structure that focuses on quality, efficient, cost-effective patient care. This is achieved by aligning the hospital and physician's incentives, which result in physician-driven value. Thank you. I'd be happy to answer any questions. You can see this, at the desert, it's not always sunny. Sometimes we have a bad day.